After his wonderful first initial talk, now he's going to talk on the second topic, community-acquired pneumonia.
Well, it's coming after ventilation. It should come before. So, community-acquired pneumonia. Fortunately, we have an Indian guidelines on this from the expert groups from PGI, AIMS, and other pulmonologists. Now, I will base my talk on this guideline. Now, let's start with this gentleman, 70-year-old man, ex-smoker, diabetic, hypertensive, started with nasal congestion, coryza-like symptoms, and then developed expectoration, shortness of breath, had fever, tachycardic, not hypotensive, tachypneic, borderline saturation. This was his PF ratio, and this was his sugar. Okay. And an X-ray done in the emergency department showed this, where he should be admitted. Let's start. Let's see. Everybody is ICU. Yesterday I had a lady with almost similar X-ray. She was little hypoxic. She was admitted in the ICU, but probably she didn't require hospital admission. CRB 65, scoring. Yes, I agree that it is not a score on which you should decide, but it's a part of it. And especially if we are in the, pay for service, insurance and all that, it's very important that we fulfill some criteria of triaging these patients. So CURB 65 have urea. We don't have urea on presentation. So just confusion, respiratory rate, blood pressure and age. This patient was 70, was confused, had a high respiratory rate. So first of all, this patient should be admitted because it fulfills 3 criteria. And just remember, confusion, respiratory rate and pressure. Q-SOFA was launched with huge fanfare recently, same. Mental state, respiratory rate, blood pressure. And this was, CRB has been there for decades. So there is nothing new in Q-SOFA. Now, whether it is ward or ICU, again, this is this criteria. There are many criteria, like there is a pneumonia severity index and all. 1 major or 3 minor criteria. So this patient fulfills confusion, tachypnea, and PF ratio. If you have 3 minor, the patient should be in ICU. So this patient should be in ICU because fulfills 3 criteria. So, but he was admitted in a general ward, and the following investigations were done. CBC, blood culture, sputum gram stain culture. Would you send a procalcitone? Let's take a vote. So how many of you would send a procal? Raise your hands. It's 50%. Okay. So we can skip this one, right? So let's go to the next one. You see, there have been a lot of talks of we should de-escalate based on procal. We should not be doing procal if we are giving 5 days, if it is a non-drug resistant, but we don't know at that time. How do we de-escalate if I don't know the initial procal? So you see, keep that perspective into mind. This procal is not going to help you then, but is it going to help you 3 days down the line? So that's why I do not look at the procal when I send it, when the patient comes. Now, what do the Indian guidelines? Very pragmatic. Do not perform. Even CRP doesn't change management. There was this recent study, 2018, whether we should be using procal in acute exacerbation in a patient who has been exposed to antibiotic. If I use procal to start antibiotic, my mortality increases. One should not be using procal, especially in patients who are on antibiotic, on presentation to the hospital or ICU. But what about down the line? If procal is declining, first of all, very low procal, I do not think it's a bacterial infection. There is an alternative infection. Can I stop antibiotic if a patient has not been on antibiotic? If I think it's a viral cap, very low procal, can I stop antibiotic? If the procal is decreasing or less than 80% from peak, how do I know this? if I do not send the first one? So I think these guidelines and the algorithms are okay, but we have to keep this into perspective. So I think we should send a procal, and declining procal, continue antibiotic therapy. Declining procal, suggest response to antibiotic. But yes, procal should not be a requirement for discontinuation. It is a clinical judgment. On the other hand, does a rising procal tells you that something else is going on. So yes, procal is helpful. If it was not the cost factor, if it was not a cost factor, I think everybody should get a procal. Now, urinary antigen, would you send it? Yes or no? For pneumococcal in this patient who was admitted to the ward. Again, as Harjit said, how many are sleeping? 2 are sleeping now. Initially, only 1. So we are making progress, Harjit. So, do you have access to urinary and legionella antigen? Let's put this into perspective. How many of you have access? Let's vote on this. How many you can do these? I'm sure you are a mix from different background. So no, so that is the reality probably in most of the places, but I think this bar is going to go up over time. So one is what is the medical part, and second is the technical and the financial part. So at the present moment, yes, we do not have so much of an access. So what is the pro and con? First of all, these urinary antigens are more sensitive and specific than gram stain and culture, because gram stain can pick up a lot of other bugs. Many patients cannot give you a good sputum sample. The results are immediately available and retains validity even after antibiotic therapy. Remember, this patient was on levofloxacin. Now, we do not grow any bug either from blood culture or sputum culture. Can this help? Paramnemonic effusion, even a pleural fluid can be tested with this kit, and you can know whether there is a pneumococcal antigen in this paramnemonic effusion. So many other fluids can be tested. What's the con part? First of all, this is applicable mainly for patients who are sick. Patients who are not that sick, it loses its sensitivity and specificity. We don't know the sensitivity. We need to grow a culture. It's expensive and not widely available. So what do the Indian guidelines say? The Indian guidelines say is not required, pneumococcal, because most of the regime that we are going to use is going to cover for strep pneumo anyway. So why using this expensive test? And considering the cost, it is not required. But they advocate the use of Legionella antigen because it's an important causative agent, can consider the duration of antibiotic. It is grown very difficult. So Legionella antigen is advocated. So normally we send Legionella, I don't find that common. In fact, we send pneumococcal more often than Legionella antigen. What do the American guidelines say? Yes, this should augment the standard diagnostic methods. So I think it should be sent, especially in a patient who cannot bring up sputum and patient who is very sick. So we sent this in this patient and both of them came as negative. The strep pneumo, the pneumococcal urinary antigen and the Legionella antigen was, this is a real case. So nasopharyngeal swab for viral PCR, would you send it? Again, we can do a viral panel, atypical pathogen. Let's see, would you? Again, you see, question is, even if you don't have, if you had access, would you send it? So probably some of you who had said no, probably because you do not have an access to it. So let's see how many of you have an access to viral PCR. Please vote. Because for urinary antigen, it was around 40% do not have an access. Let's see, because this has become such an important test now for CAP. I think it's very important to keep into perspective how many of us have an access to this. So a lot of people have an access to viral PCRs, an atypical pathogen, which is nice to know. So let's look at the pro and con. It improves the accuracy, there's no doubt. Very rapid turnaround time, mycoplasma chlamydia, we will know, rapid diagnosis of viral pneumonia. Can it mitigate the use of lot of big antibiotics? What is the con part? 15% of healthy persons harbor a respiratory tract virus. So if you have a virus, that doesn't mean this patient have a viral pneumonia, except if you have influenza virus. We don't have a semi-quantitative or quantitative PCR, so we don't know the load, so we don't know what exactly is the pathogen. It's expensive. So again, there's a pro and con. So what do the Indian guidelines say? Investigations should not be routinely done, because our armamentarium will cover atypical agent anyway, and PCR-based respiratory viruses do not influence antibiotic coverage. Everybody gets an antibiotic anyway. Well, I would rather take a different view on this. My philosophy is it is important because of the subsequent discussion. I think you will agree that knowing the pathogen, even if it is a virus, will be important. Now, what is the most likely pathogen in this patient? Patient where pneumococcal was negative, Legionella was negative. Most likely pathogen of all the big epidemiological studies. Well, of all the studies which have been done so far, 60%, there was a big NEGM study, no pathogen detected. With almost all the investigative armamentarium you have, in 60%, no virus, no atypical, no bacteria has been detected. So strep pneumo is said to be the number one in almost all the studies. But now the scenario is changing. We are in a different era. This patient gives a history of pneumococcal and influenza vaccination just a few months back. Now what do you think? So probably the strep pneumo comes down, isn't it? So let's start with this. What should be the empirical therapy in this patient? He gave a history of pneumococcal vaccination, remember? Let's see, are we still going to cover ceftriaxone? That's our age-old. Just think about it. What are the chances of this patient having strep pneumo or ceftriaxone sensitive organism? So this patient was admitted in the ward. In the ward, usually a patient who is not that sick to be in the ICU have pneumo, strep pneumo, respiratory virus, mycoplasma, H flu, legion. These are the usual organism. The Indian guidelines says, yes, in patient admitted to the ward, beta-lactam, any of these, fluoroquinolone should not be used. That's the Indian guideline because of the fear of tuberculosis. And tetracycline there is not much recommendation. So probably combination of beta-lactam plus a macrolide. But remember, this is an era of individualized medicine. We have a precision medicine. This patient had a pneumococcal vaccine. So what should we be doing? The American guidelines for the ward patient, more or less the same. They have also added ertapenem and this new molecule ceftaroline, which might be coming very soon. They advocate doxy and quinolones, which we don't. Now, remember, this patient had a coryza-like illness. He started with cough, nasal runny nose. Should this be added to this patient? He has got a pneumonia now, but he started with influenza-like illness. Would you add oseltamivir? Or most of you. Interesting. Remember, he had an influenza vaccine as well. So, what does the recommendation says? In spite of vaccination status, because there are so many strains, if we are in epidemics or we are suspecting influenza, yes, there is no harm in starting oseltamivir. And always remember, virus, bacteria, and fungi, they can come in combination. Commonest cause of death in viral pneumonia, in influenza, is bacterial pneumonia. Millions of people died of epidemic, and the autopsy studies showed that they died of not influenza, but bacterial pneumonia. Now this patient deteriorated. He was admitted to the ward, started on ceftriaxone and azithromycin, deteriorated. His urinary antigens came negative, was shifted to ICU, required mechanical ventilation. Apart from the antibiotic, should we add steroids to this patient? What do you think? Very sick patient admitted, no. Oh, interesting, no steroids. Severe CAP, this patient has severe CAP. Indian guidelines, yes, not recommended in non-severe CAP. It is recommended, again, a very fuzzy guideline, ARDS and shock. This patient was not in shock, but had a severe CAP requiring ventilation. What is up-to-date recommendation? I usually go for this. In a severe CAP, if a patient has more than 150 milligram or even 200, steroid have got lot of good effects. Just like meningitis, we don't even think twice for giving dexamethasone in bacterial meningitis. It's a closed space infection. So yes, steroids for 5 days. Now this might be a problem in these patients. Poorly controlled diabetes. We need to know the HbA1c of this patient. In poorly controlled diabetes, I exclude steroids. But yes, otherwise steroids should be given. Again, this is a problem. Influenza. If a patient had influenza, the literature is not very clear. Is it influenza with bacterial pneumonia or is it influenza pneumonia? Then you should not give steroid. I think in both of the situations, one should not give steroids because it has been found to increase mortality. Influenza pneumonia, in corticosteroids, the hazard ratio is more than 1. So yes, influenza one should avoid. Now this was this patient's viral panel, PCR panel. It was all negative, including atypical was negative. So yes, this patient didn't had influenza. So probably if his sugar was not too high, one could start steroid. These are the organisms which are usually found in very sick patients in the ICU: strep pneumo, Legionella, gram-negative, staph, and influenza. These are the classical risk factors for gram-negative. This patient had previous antibiotic therapy. This patient was COPD. This patient had diabetes. So quite a few factors for gram-negative. And as soon as you start hearing a pneumococcal vaccine, an influenza vaccine, urinary pneumococcal negative, Legionella negative, your viral panel negative, in our country, you can't just treat this patient with ceftriaxone. The chances are very, very high this patient has a non-strep pneumonia. This patient probably has a gram-negative infection. MRSA, yes, there are, again, you'll find similar risk factors in almost all of these. So by risk factors, at least my personal is you just can't differentiate one from the other. So Indian guidelines, if there is no risk factor for Pseudomonas, again, just like severe community acquired, but if there is a risk factors for Pseudomonas, then these things should be added. And I think in this patient, given the background of all this vaccination, should be treated for gram-negative. This is the recommendation for gram-positive. Remember, this is the new thing. If you have to cover for vancomycin, with vancomycin, and you are giving piptase, vancomycin should be changed because there is a big chance of AKI. There are quite a few literature over the last 1 or 2 years. These two combinations are notorious to cause renal failure. Now this patient also grew Klebsiella. It looks like this is the new Pseudomonas, Klebsiella. Now Klebsiella, this is resistant, this is ESBL, resistant to cephalosporin, sensitive to piptase, and sensitive to carbapenem. So ESBL Klebsiella, which one would you choose? Patient has ESBL, it is sensitive to piperacillin tazobactam. What would be your drug of choice? Meropenem. Some of you would choose, some of you choose colistin and mero. Yeah, we have a sensitivity here. Now, the game has changed after this study where they looked at all ESBLs, compared piptase with meropenem, and they found piptase to be inferior even in a less sick patient, even in a patient with MIC to piptase less than 8, even in a patient with urinary tract infection. These are the classical patients where you used to say that, okay, piptase is good enough. Patient is not very sick, urosepsis, MIC is low. So let's give piptase. In the others, give meropenem if patient has ESBL. Even in those patients, they found there is a mortality benefit. Lastly, duration of antibiotic therapy. Just like what Harjeet has mentioned, all pneumonia lectures should finish on this. What do you think? B. Oh, he has taught, Harjeet has given you the lesson, but I would go for none of the above. We do not know. Every patient is different. Indian guidelines 5 to 7, but I would say, the only way, we cannot stop giving patient upfront antibiotic, especially in our, whether it's community, whether it is hospital. We have so many of bad bugs and you can't take chance. But if I have to restrict the antibiotics, if patient has a good response, if I have a biomarker, apart from, clinical good response, if there is a biomarker response to less than 80%, and that's why the first CRP and the first procal becomes very important. A procal of 250, procal of say 20, 30 or even 10, if it comes down to 2, you can stop the antibiotic, or the CRP comes down. But these are the classical where prolonged antibiotic therapy is advocated. So to summarize, I just overview of triaging by the scoring system, pro and con of urinary antigen, the viral, the atypical PCRs, what are the likely pathogens we have to face in the ward and the ICU, take a vaccination status, do a urinary antigen, if possible do a viral PCR, because rapidly change to a gram-negative cover, strep pneumo might become less likely. The risk factors for Pseudomonas, when to use antiviral, steroid, BL-BLI versus carbapenem, and just a quick discussion on duration. Thank you. Thanks a lot.
I would like to request Dr. Bharat Purandare to kindly facilitate Dr. Todi.